Unable to start video. Good morning, everyone. Many thanks for joining us today. And many thanks to all the panelists. Sorry, we have a bit of an echo. Okay, so thank you everyone for joining in early. We are now ready to start. And today we are very privileged again to have the OBS and Gynae team join us. They'll be presenting the cases and leading the discussions. In a short while, I will hand over to Dr. Rose, who will introduce the rest of the team and take us through the program. Please feel free to send in any questions you might have. We will go through the questions at the end of the presentations. So once the OBS team is over, we're also very privileged to have with us Dr. Maritim, who will share with us insights into vaccination and issues around vaccination in pregnancy. So Dr. Kavan, karibu sana.
Good morning, everybody, and welcome to today's webinar. And today we are going to look at the critical patient who is pregnant and with COVID-19. And the main question we want to answer today is, when do we make the decision to deliver the patient? And I think that is the biggest question surrounding these patients who are critically ill. And to start us off, I'll start with the introductions. Our first presenter will be Dr. Karen Mudemba. Dr. Karen Mudemba is one of our residents, as third-year student at the Department of Obstetrics and Gynecology. She has summarized a case of a patient who was admitted in our ICU, and that will be our first presentation. Also with us is Dr. Nyukuri, who is an infectious disease specialist at Kenyatta National Hospital. And the other panelist, Dr. Olang, Dr. Patrick Olang, is a biologist at the Department of Surgery, University of Nairobi, and a specialist in Kenyatta National Hospital. Dr. Anne Beatrice Kihara is going to give us our PowerPoint presentation. She is a senior lecturer in the Department of Obstetrics and Gynecology. She is also the AFOC president and the past COGS president. And our other panelist is Professor Omondi Ogutu. Professor Omondi Ogutu is an associate professor at the Department of Obstetrics and Gynecology and our past immediate chairman. The other panelist is Dr. Mary Beth Maritim, infectious disease specialist, a senior lecturer, Department of Internal Medicine. And we also have Dr. Lois Acheng, who is our session chair today, senior lecturer, Department of Internal Medicine. So welcome everyone, and over to you, Dr. Karen Mudemba, who will ask you to kindly share your screen and proceed. Thank you and welcome.
Good morning, everyone. Thank you so much, Dr. Kosgei, for the introduction. Can you hear me?
Yes, Dr. Karen, we can hear you. We'll just request you to put your presentation on slide view. Thank you.
Okay, thank you very much. My name is Dr. Karen Mudemba. I'm a resident of Obstetrics and Gynecology. Today, I will present to you a case summary of a patient that we had in IDU care in Kenyatta National Hospital, and she did have COVID-19 in pregnancy. I'll start with a brief introduction. Our patient today is PM, 27 years old, para 3+0, gravida 4. When she was admitted, she was at 31 weeks, 2 days with severe COVID pneumonia, severe pulmonary artery hypertension, also pulmonary thromboembolism. And she was a referral from Kajiado County Referral Hospital. The date she was admitted was on the 3rd of August, 2021 at 4:30 a.m. Unfortunately, she died on the 8th of August, 2021 at 2:30 a.m. So the length of stay that we did have this patient was 5 days. So I'm going to go each day as we manage the patient so that we can give you a detailed information on what we did. So she was referred from Kajiado Hospital. On the day of admission, this was on her referral letter. She presented with blood-stained productive cough for 1 day at that hospital, which was associated with left-sided chest pains radiating to the shoulder and difficulty in breathing, even at rest. She presented with fever and chills as well. There were no night sweats, no orthopnea, no lower limb swelling, no history of cardiac disease or hypertension, and no history of TB contact. On examination at the referral center, she was sick looking and in obvious respiratory distress. Her blood pressure was 110/67. Her pulse rate was 92, SpO2 62% on room air, and 94% on 15 liters of oxygen via non-rebreather mask. Her respiratory examination showed cause crackles bilaterally. On the CVS examination, there was a hyperactive precordium with a systolic murmur. The location was not given on the referral letter. Her abdomen, she was at 30 weeks with a longitudinal lie. The fetal heart rate was 136 to 142 beats per minute, and she was oriented in time, place, and person, and had no lateralizing signs. The investigations done there at the referral hospital, they did a COVID antigen test, which was negative. They presented an ANC profile, which she had in her book. Her blood group was B positive. HIV and VGR and syphilis was non-reactive. Her full hemogram result was white blood cells was 10.1, HB 13.8, platelets 218, and an RBS of 6.2 millimoles per liter. So the management she got at the referral hospital was the ceftriaxone, azithromycin, vitamin D, zinc, clexane, and Lasix. And the reasons for referral was severe hypoxia for further management. And that's when she came to Kenyatta Hospital. On day 1 in Kenyatta Hospital, now when she was received by the doctor at labor ward at 4:10 a.m., she presented as para 3+0. Her EDD was 29th of September. This should have been this month. Her presenting complaints were chest pain for 1 day, which are left-sided, radiating to the right shoulder, associated with shortness of breath at rest, and the cough was productive. Her obs-gyn history was as mentioned. Her past medical history, there was no history of hospital admissions, no history of chronic conditions. Her family social history, she was married, no history of smoking or alcohol use. On examination on admission, she was in obvious respiratory distress on oxygen. She was actually on high flow via non-rebreather mask. SpO2 of oxygen was 20% and on oxygen was 90%. Her blood pressure, 110/87, and the pulse rate was 92. Still on day 1 on examination, her abdomen was soft, moving with respiration. Fundal height was 30 weeks. There was no obvious organomegaly. Her CVS exam was unremarkable at the time. Her respiratory exam, there was bilateral cause crepitations and chest dull to percussion. Her CNS also remained normal on the first day. Impression made was para 3 plus 0 gravida 4 with severe pneumonia, query COVID-19 pneumonia at 31 weeks and 5 days. So the plan was to do lab works, that was the full hemogram, UECs, LFTs, D-dimers, BGAs, and obstetric ultrasound, shielded chest X-ray, and to keep her propped up in bed on high flow oxygen, monitor oxygen saturations, ceftriaxone, azithromycin, paracetamol IV, dexamethasone, 6 milligrams IV. She was also given dexamethasone, zinc, COVID-19 PCR test was to be done, and Clexane, gene expert and pulmonologist review, together with an ECG echo. At 2 p.m., and that's the same day, BGAs came out. So we got a pH of 7.356, a PCO2 of 3.6, HB of 13.4, and bicarbonate of 14.7, potassium was 2.9, and oxygen was 79.6. So what we found was a compensated metabolic acidosis. So we waited for the other results. In the meantime, potassium, since it was 2.9, was supplemented with 20 milliequivalent in 250 mils of normal saline over 4 hours. A repeat BGAs was to be done in 6 hours, and if it persists, to repeat the dose of potassium. Dexamethasone was still given together with ascoril, and the recommendation was to give steroids for 10 days until saturation was more than 90%. Other medications were to continue as prescribed. On examination at that time, she had fine crepitations bilaterally. Her vitals were blood pressure 117/83, pulse rate 131, now it's gone up. Fetal heart rates remain normal at 130 beats per minute. Temperature was 36.7, SpO2 75% on oxygen. On day 2, this is still in labor ward, and that was on the 4th of August 2021. The full hemogram results came out. So we had a HB of 14.8, white cells of 8.84, platelets of 292. The UECs were fairly okay. Urea was 1.4, creatinine 54, potassium was 3.6, LDH was elevated at 739.5. We had the LFTs as well. ALT, AST were within normal. ALT was 15, AST was 29, but total bilirubin was 29.2. Direct bilirubin was 11.7, and we had a GGT of 53. The coagulation profile, the INR was 0.89, APTT was 35.3, and the COVID test came out positive. That was the PCR test. So we awaited the ECG echo and shielded X-ray together with an OB scan. On examination the next day, she was fair general condition, afebrile, on oxygen via non-rebreather mask. SpO2s were 87% on 15 liters of oxygen per minute. Blood pressure was 112/72. Her respiratory rate was 34, pulse rate 120, and on examination at the chest, there was fine bilateral crepitations. Abdominal examination was the same with a normal fetal heart rate. Plan was to do ECG echo, shielded X-ray, and continue the medications. During the handing over ward round, we do morning and evening handing over ward rounds at labor ward. We had gotten the ECG echo, and the results showed good biventricular systolic and diastolic function with an ejection fraction of 68%. There were dilated chambers, severe pulmonary artery hypertension, moderate tricuspid regurgitation, no regional wall abnormality. The ECG showed sinus tachycardia, moderate voltage criteria for left ventricular hypertrophy, T-wave abnormality, and we were to consider inferior ischemia. So the plan was cardiologist review, awaiting possible transfer to IDU. On day 1 of IDU, which is day 3 of admission at Kenyatta National Hospital. Now she was transferred to IDU. The first examination, she was sick looking, on oxygen at 15 liters per minute. She had warm peripheries, blood pressure 123/78, pulse rate of 95 beats per minute, temperature of 36.3 degrees Celsius. Her GCS was 15/15. Fundal height 30 weeks, fetal heart rate remained within normal. There was no respiratory exam notes that I found. So the plan was to maintain on oxygen and reassess need for non-invasive ventilation, that's NIV, do BGAs, OBSCAN, cardiology review. The cardiologist came in view of the echo findings and history of hemoptysis. So they diagnosed PTE being highly likely, that's pulmonary thromboembolism. That was highly likely secondary to the risk factors and COVID-19 in pregnancy, causing high pulmonary artery pressure of 76 millimeters of mercury. And the plan was to continue Clexane at 80 milligrams twice a day, and hydralazine was added 12.5 milligrams orally. On day 2 in IDU, which is day 4 of admission in Kenyatta Hospital, her issues were patient was desaturating on high flow nasal cannula and non-rebreather mask on full anticoagulation. On examination, she was not pale, not jaundiced. It was not mentioned whether she was cyanosed, no edema or dehydration, and the blood pressure was 128/56. Pulse rate remained above 100 at 115. The FiO2 was 100%. She had been given a non-rebreather mask at 15 liters per minute. Her respiratory rate was 47. It has been rising. SpO2s remained at 77 to 82%. Her CNS was at 15/15. No neurological deficits found. Her RBS, however, was at 8.3 millimoles per liter. And the repeat BGAs that had come back showed a pH of 7.43. Her partial pressure of carbon dioxide was 4.1. And then we also had a PO2 of 7.3 and HCO3 of 20.2. It was compensated metabolic acidosis with hypoxemia. The plan was consult between physician and obstetrician and deliver the baby urgently. On day 3 in IDU, which is the day 5 since admission in Kenyatta Hospital, she delivered a live male infant, birth weight of 1730 grams. Apgar score was 9 at 1, 10 at 5, and 10 at 10, and the baby was admitted in NBU. The blood loss, estimated blood loss was 300 mils, and the patient was wheeled back to IDU. It was an emergency cesarean. Post-emergency cesarean section, this is at 3 p.m. on day 5 of admission and also day 3 in IDU. She was breathing on a non-invasive. She was on, her SpO2 was 92%, blood pressure 111/72, pulse rate remained at above 100 at 122. Her GCS was 15/15. Her abdomen, the uterus was the fundal height was at 18 weeks, well contracted, minimal local loss, but there was noted that she had an ulcer on the left leg around 5 centimeters. It's not clear as to what circumstances or when it developed. So the plan was to monitor vitals, monitor the PV bleeding, analgesics, resume Clexane on second day post-delivery. Unfortunately, when you were going into the eighth day, which should be going to day 6, patient was very restless and agitated. There was that laceration on the right leg around 6 centimeters. It was septic with a necrotic region. She was desaturating at 80% when agitated. On examination, she was sick looking in respiratory distress. There was no pallor, jaundice, cyanosis. She was not dehydrated. Her SpO2 was 80 to 88% on NIV and CPAP. Her respiratory rate was 35 breaths per minute. Her blood pressure 135/103. Her pulse rate 85. Temperature 36.1 degrees Celsius, and her RBS was 4.6. So the plan was to keep her on nil per oral for 24 hours, continue IV fluids, resume Clexane on day 2 post-op, monitor vitals closely, sedate, dressing of the wound. At 2 a.m. On the 8th, patient was diaphoretic with sudden deterioration, unresponsive with no palpable pulses and no respiratory activities. Resuscitation commenced according to the ATLS protocols, which was unsuccessful. Patient was certified dead at 2 a.m. So that's a very, very small show of how the blood pressures were. I've just indicated the main ones. So you can see that the blood pressure from the day she came all the way to the 7th, they remained normal, but also started to go up from the 5th. And they went up to 135 to 100 over 103. Her pulse rate, however, has been on the increase from the day she was admitted all the way to the day, the 5th day. Her respiratory rate also increased from the day she was admitted all the way to the 5th day. Her SpO2s also have been on the decline. We've also noted that her temperatures remained normal during her examination. The random blood sugar also had been dwindling, with the last one being 4.7. The potassiums at the beginning were low, but with intervention, they went back to normal. But the urea electrolytes and the liver function tests were deranged, but the urea electrolytes were fairly normal. Thank you. And thank you to all the frontline workers.
Thank you very much, Dr. Mudemba, for that very well presented case summary. And I want us to just have this question on the parking lot, even as we welcome our second presenter, and Professor Omondio Gutu and Dr. Olanya in the panelists. At the end of Dr. Kihara's presentation, I will want us to ask ourselves, what causes the sudden downward trend after delivery of this critically ill patient who is COVID-19? Right now, we're going to welcome Dr. Anne Beatrice Kihara, who is going to present a PowerPoint presentation on the timing of delivery with COVID-19 patient requiring intensive care unit. I must comment that this PowerPoint was a collabo of all those people that you can see on the screen. Dr. Kihara, over to you.
Thank you very much, Rose, and thank you, Dr. Mudemba. And thank you for also giving the opportunity to OBSGYN. We really appreciate it. And I'll start with this first slide. As my colleagues and myself actually put this together, the biggest dilemma we have: are you doing the right thing? Are you doing the wrong thing? Are you making the correct choices? And above all, are you deciding appropriately or inappropriately? And this is really what we want to tackle, bearing in mind the case that has been presented and the women that do see us when they are critical. Am I advancing? Okay, so this will be the outline we will take. Give a brief introduction, the criteria which is critical for determining whether a patient is severe or critical, and what does the evidence say so far, and what should we therefore consider as our management algorithm. 13% of pregnant women who contract COVID-19 become very severe in the disease state, of which 4% end up in ICU admissions. Most in pregnancy tend to have mild disease. And if you recollect last week, we tend to see the more severe patients coming in the 3rd trimester. The timing, therefore, of delivery in a critically ill COVID-19 patient presents a big dilemma, And the common cause or the common issue that we really have to grapple with is the iatrogenic premature delivery of these women. There is therefore need for a multidisciplinary team approach. And you can see you have the IDU specialist, you have the physician, you have the obstetrician, you have the anesthetist. There's a whole cocktail of doctors who really have to put their minds together to manage the patient. And we cannot overemphasize the need for family conferencing. And it should really begin immediately this patient is admitted in the hospital. Both maternal and fetal status must be simultaneously taken into account. But remember, pregnancy in and of itself increases the risk for mechanical ventilation. And as the gestation gets bigger, by the time you're hitting 36 weeks, it is just below the diaphragm. So you can already see physiologically there's a constraint. And with COVID-19, where you have now affect to the respiratory system, then the risk for mechanical ventilation or even extracorporeal membrane oxygenation increases. Mortality and data is suggesting a higher rate of intrauterine fetal demise and including premature delivery. So what therefore do we use as the criteria for severe or critical COVID-19 disease? And as I flagged it last week when I presented, I said the respiratory system really is the hallmark of what we should be looking at in terms of how is the patient on receipt and how is the patient deteriorating and at what rate. And you can see for severe diagnosis, we've used two different study areas. Respiratory rate tends to go up above 30. SpO2 is less than 94 on room air or less than 93. The fraction inspired oxygenation is less than 300. Lung infiltrates in the majority, you will see them in over 50%. Then you have the critical respiratory failure, where the patient actually progresses from the nasal prongs low flow all the way to actual mechanical ventilation. Septic shock and multi-organ dysfunction really tells you this is a very severely ill patient, which is what has been presented by Dr. Mudemba. But there are people who are even going further and saying, we want to actually separate, even from the severe patient, who do you deem as critical? Where you're saying you've got to now escalate and have active management of this patient. The difference is this. You have in severe patient an acute hypoxemia and respiratory failure, septic shock. There may be neurological sequelae. So the patient presents with delirium or an encephalitic picture, or even for some, they may have obvious lateralizing signs. But in severe cases, you have multiple organ dysfunction. And I dare say we must rule out existence of other comorbidities, be they medical. And when I say medical, it could be diabetes, it could be hypertension. But don't forget, we're in the tropics. It could also be infective diseases. So you could have comorbidities with malaria, comorbidities with HIV, comorbidities with TB. For critical patients, what do you begin to see? Beyond and above the acute hypoxemia and respiratory failure, there'll be the septic shock. Thromboembolism is actually thought to be one that heralds this is a really critical patient. Again, rule out existent comorbidities. But in this case, now you're crashing multiple organ failure. And it is critical that you do sequential organ failure assessment, or what is known as the SOFA. So what does the evidence say? Most of our pregnancy outcomes, we are looking at epidemiological reports and case reports. We cannot do RCTs. Preliminary data, however, suggests preterm delivery occurs in 15 to 29% of patients with COVID-19, and cesarean section really is what people tend to perform. And this is high at 38 to almost 89, 90%. For the neonatal outcomes, it depends on the gestation. And I'll repeat this, it depends on the gestation. Those delivered above 32 weeks have a more favorable outcome, and vertical transmission is thought to be rare in pregnancy. And we have a few case reports, however, which say it's about 3 to 5%. But most of the neonatal complications occur because of the iatrogenic prematurity. So what therefore informs guidelines on management? This is derived from the experience and not clinical trials. With COVID-19 pneumonia, the principles are similar to non-pregnant patients. However, we modified with the medications and even maternal positioning. Remember, the mother is still carrying a baby most of the time. Decisions regarding frequency of the fetal monitoring and delivery are governed. 1, how is the maternal status? 2, how is the fetal status? What is the gestational age? But you must always rule out the presence of comorbidities. So what then becomes the criteria of refractory maternal hypoxemia? And Mudemba was very good in terms of building up the case that we have just listened to. A partial pressure of oxygen of less than 60 millimeters of mercury while receiving a fraction of inspired oxygen of 1. On the clinical basis, this definition can be expanded further. Severe hypoxemia, a fractional of inspired oxygen of less than 150. Unresponsive incremental increase in positive end expiratory pressure. Recruitment of lung volume. Remember the pathology and the pathophysiology that's happening with COVID-19. It attacks the alveolar regions. So most of the lung tissue may be consumed by the infection. Worsened off by even the spread of the immunofactors that come to play, the cytokines that are really teaming up in that patient's body. People talk of prone position in nursing. This may be a challenge, particularly when she is pregnant. And others even talk of deep sedation. Advanced therapies such as the use of pulmonary vasodilator medications or venovenous extracorporeal membrane oxygenation are often considered when the patient is dire. However, complications of hemorrhage requiring transfusion occurs in 56 to 67%, and infections are common, 58% with ECMO. The requirement for continuous anticoagulant therapy introduces a further complicating factor in the event of an unplanned delivery because of the risk of hemorrhage. But what are the parameters for urgent delivery in a critically ill patient? Admission to the ICU for COVID pneumonia does not in and of itself constitute an indication for delivery per se. However, pay attention to this. Refractory maternal hypoxemia, you must move. Non-reassuring fetal status, and there you have to now weigh, is my baby less than 34 weeks or above 34 weeks? And is the mother stabilizing when she is put on oxygen? If she does not improve with oxygen, because we normally start from low flow into high flow, non-intubator to intubating to ECMO. So if you're cascading her baseline oxygenation to be within the normal with more aggressive intervention, you need to really consider delivering that mother. The method of delivery is individualized and is based on the maternal clinical status, the fetal condition, obstetric history, or a compounding obstetric complication. I've gone back to my meow chart because I really feel this is something we all need to have in our units. For the simple reason, the maternal early obstetric warning scorecard can tell you how critical and when to trigger escalation of care. Under normal parameters, you can see that will be reflected in the white zone. The yellow zone alerts us. But if you have 2 yellow zoned parameters, you must treat that patient the equivalent of the red alert. And I have given you the parameters and what they should and should not be. By red alert, you honestly need to be calling everybody onto that patient's care. So how do we then decide what is the method of delivery? Yes, successful induction of labor for mechanically ventilated patients with COVID-19 has been described. However, more oftenly, the babies develop non-reassuring fetal status in intrapartum up to 34%. Therefore, an emergency cesarean delivery may represent the most pragmatic option, like it was done for our patient. Avoid pressures and manipulation, which will irritate the diaphragm. So even intra-op, I know we normally want to pack the gut away, but be careful and gentle with how you handle your patient. Currently, there is no evidence that the route of delivery adversely influences the maternal prognosis. But we do have anesthetic issues that you must be cognizant of. And I will start with what we began to talk about last week, aerosol spread of the virus in the delivery or operating room during emergency endotracheal intubation. Avoidable through early insertion of epidural catheter for labor and delivery. Difficult endotracheal intubation, particularly because of laryngeal edema in these patients. And the fact that you may need to do a cesarean start, leading to maternal and fetal hypoxia. An iatrogenic pneumothorax or surgical emphysema due to pulmonary barotrauma from high PEP can occur. You can also have complications associated with both spinal and epidural anesthesia, some of which are severe hypotension, convulsions, unconsciousness, respiratory and/or cardiac arrest. So our battles do not just begin and start with the mother. You have to look at other complications that surround her. So what are the recommendations at the time of ICU admission? 1, prophylactic anticoagulation. You may administer remdesivir, dexamethasone, and or other FDA-approved therapeutics according to your institutional protocols. An obstetric ultrasound is so essential for fetal surveillance. And to note that you are actually providing critical care for this patient. So let's come to the gestation. Less than 24 weeks, pre-viable baby. You may perform interval auscultation of the fetal heart rate. Delivery would only be indicated in the event of maternal cardiopulmonary arrest at a gestation. In this case, you're doing a resuscitative cesarean delivery. The relatives must be involved and must be fully aware of the indications and the possible fetal outcomes. Gestational age that is higher, 31 weeks. Antenatal corticosteroids can be given. And this is really for lung maturation in the fetus. Daily fetal assessment in the setting of a stable maternal clinical status and oxygen requirement. Convert this, however, if the maternal condition becomes unstable, to continuous fetal monitoring, the employment of CTGs. Consent for cesarean delivery needs to be taken early enough. You must continue your multidisciplinary approach. You must continue having your family conferences. Delivery is then expedited if you have non-reassuring fetal status in the setting of refractory hypoxemia, because you want to actually optimize the mother's breathing once you have actually evacuated, so to speak, the fetus. Interventions to improve also the fetal status may then be attempted extrauterine. If a decision is made to deliver, in this case, discontinue anticoagulation therapy for 12 to 24 hours in advance because of the risk of hemorrhage. You may also give magnesium sulfate for fetal neuroprophylaxis in these selected patients. What if a gestational age beyond 34 weeks? We're getting better and closer to term. Daily fetal assessment continues where the mother is stable. Then, as we had earlier on said, if the condition becomes unstable, you must put her on continuous fetal monitoring. Consent for cesarean delivery needs to be taken, a multidisciplinary approach, family conferencing. Delivery must be considered for any situated deterioration in the maternal pulmonary status. If the decision for delivery is made, discontinue anticoagulant therapy 12 to 24 hours in advance. So this is the management algorithm, but I'll move to the next one, which is a bit clearer, which really just then summarizes what we've been saying. A pregnant patient is admitted with COVID pneumonia, like our patient was, diagnosed to have severe or critical disease, reflected by the parameters that we have already spoken about. What should you then do in light of her severity? Again, use the protocols that you have within your institution. One, taking cognizant. There is the mother, there is the fetus, there is the gestation. And there may or may not be other comorbidities that you must be addressing yourself to. So this just then summarizes for all of us what we should then do in a pre-viable, viable from 31 weeks all the way to term. So those are our selected references. I do hope from today we can be able to manage the critical and also the severe COVID-19 in pregnancy. Thank you very much.
Thank you very much, Dr. Kihara, for that well-presented PowerPoint. And right now, we're going to open the floor for our panelists for comments. And I'd already, on top of all the other comments, Professor Ogutu and Dr. Olang, you give us a comment on whether we delayed to deliver these patients, or we did it at just the right time, or what would we have done better. And I'll go to the infectious disease team. You'll help us to just discuss the issues surrounding anticoagulation, steroid use, antibiotic use, and the investigations that at minimum we require for these patients. And so we'll start with Professor Omondi Ogutu, followed by Dr. Olang.
Thank you, Dr. Kosgei, for asking me to make some comments, and also for Dr. ABC for a good presentation. Dr. Karen for having given us a very good summary of the case at hand. Now, currently when you talk about COVID, I'll talk about a few things on COVID-19 in pregnancy, and also in reference to this patient. Now, one of the things which we are currently seeing now, because this is a disease of recent onset and we are learning by the day, the first and the most important lesson we should learn currently in managing patients with COVID in pregnancy is that we must have a team leader, because we are managing this patient as a multidisciplinary team, but we must have somebody who is in charge. If it is the obstetrician, yes, because she's pregnant, or if it is the ID specialist is in charge, then somebody has to take the lead so that decision-making is coordinated, shared, and discussed and agreed upon. Now, looking at the case, I will first of all make a reference to this case. We had a para 3 gravida 4 with what presented as severe pneumonia at 31 weeks with very high index of suspicion of having COVID-19 disease. Now, the general consensus which is coming up currently, if you look at several literatures coming from most of the countries where they have had a bit of an overload of COVID-19 is that once you get to a gestation of 32 weeks and there's significant evidence that you see that your patient is beginning to deteriorate, then you should be able to make an early decision of when do you deliver. So 32 weeks to 34 weeks, you should then be able to make a decision of when am I going to deliver? Do I have a good neonatal unit? Yes, if this patient is admitted, like our patient was admitted to the ICU, and if you find that the patient is generally stable and you can be able to manage without any other, all the other parameters are not deteriorating, then you may decide not to deliver. But watch out. All the patients who are pregnant and have got COVID-19, you'll always find that the idea the physician will tell you this, something else wakes up in this patient. And even a patient who did not have a comorbidity, you start finding that something happens. Are we getting hypertensive disorder, which will start and then you get like a preeclampsia-like condition in this patient? Are we having an endocrine derangement, either because of the blood sugar derangement? Are we having an elevation of the thyroid levels? You get a thyrotoxicotic kind of event. So something starts happening. Then you start getting a renal derangement with electrolytes coming in, like in this patient. And of course, you start getting your respiratory either component derangement. And then the patient now get a fluid and very rapid response to the disease condition, and your patient now start deteriorating. Now, pregnancy now becomes a nidus of creating more and more significant events in this patient. And that's why there's now a push that the moment you get to 31, 32 weeks or onwards, then, and this patient still has not started showing those negative derangement signs, please try and institute a delivery. Now, the question here will be, can you be able to induce, or do you be able to do a cesarean section? If you make your decision early and this patient has not shown any signs of deterioration, like was in our patient, you can be able to induce and you get away with it. Less than 4% of patients who have vaginal deliveries usually respond very well. Now, when you do a C-section, a higher percentage, more than 15%, and the figures seem to be rising because we are getting to get to know more and more and more reporting, because there are other comorbidities we set in with the intervention of surgical intervention in this patient and in the process of anesthetic component, which Dr. Lang will talk about. Therefore, it would be prudent to deliver these patients early. If you look at this case, we delivered her by C-section on day 5. We could have been a bit more proactive, and maybe, you know, it's good, retrospective medicine is always easy to deal with, but probably we may have been able to delay some of these elements of derangement because, you know, we had already reached a point of suspecting PE, we are on Clexane of 80, we had already developed metabolic acidosis, and the patient already a very sick patient. So within this element, the patients tend to be lost. So the element, the main aspect of presentation of this case was for us to look at and educate ourselves as at what point, what would be your trigger to make a decision that I am going to intervene. Of course, from the obstetric point of view, once you find that there's any evidence of deterioration of the fetal status, then you will be able to easily, excuse me, sorry for that. Once the derangement of the clinical status, I mean, the status of the fetus you'll be able to intervene, what we call non-reassuring fetal status. But this is now where the element of the physicians come in. The moment we start seeing evidence of deterioration, let us make a bold decision and deliver these patients. I'll bring this up with the kind of experiences I've had, because it's a learning exercise in some of these patients, whereby by the time you delay in instituting deliveries, patients who present with this kind of scenarios, you will find that after delivery, there's that lull, and you find that some of these patients will give you an impression that they improve within maybe 1 or 2 days. Then you get the acute episode of patients, because of their delayed immune status, they start getting some evidence of low-grade infection. Our patient did get a fever. I don't know how relevant the wound which we had on the leg, which was septic. Could that have been a site of what was bringing up all the other derangement, giving us the very fast deterioration in this patient? So after delivery, a number of things kick in. And this is where now the changes in the metabolic state in the patient, then the hemodynamic status also changes. The large placental bed in a patient with deranged lowered immunity may act as a site for infection. So if we already delay and the patient has already become sickly, then we might be able to get a good baby, but the mothers always tend to have poor outcome. This has also been shown in some recent reports from Spain, whereby they are looking at the modes of delivery, and where they intervene early and you induce labor and you get vaginal delivery, you find that the outcome are much better. When you delay and the patient condition starts getting worse, and therefore cesarean section is now done as a means of trying to salvage the situation, then your ICU admission almost goes post C-section in the ranges of 20% and above, and a number of these patients tend to succumb. Similar findings have also just been reported from South America, in Mexico, which have also shown the same kind of thing. So my take would be, we should be able to make a bold decision. If you have a patient, it's COVID, and you're beginning, and the baby is at that gestation where viability is almost assured, if you're in a good center with a good neonatal care, then you are better off delivering this mother before the other factors set in, because when they start getting sickly, the deterioration process, especially in those patients who will require admission to the critical care unit, once they get there and they are pregnant, please, we just know that we are racing against time, and the outcome, even if you deliver the baby and you get a good baby, the maternal outcome is usually very, very worrying. Some of them may stay for so long in a very acute state, and eventually, unfortunately, you end up losing some of these patients, and it becomes a very, very critical thing. And you start looking back that could I have intervened early? And this is always what affects us as clinicians. And you start auditing yourself. If I had done this earlier, could I have saved the kind of scenario I found myself in? Thank you.
Thank you very much, Professor Omondi-Ogutu, for that comment and really giving us how we should approach this patient and try to get the best outcome for both, but if it's not for both, then at least for the mother. And so next, for the next panelist, I'll request you to try and give the comments very quickly. And now we are over to Dr. Olang. Dr. Patrick Olang, the floor is yours. Dr. Olang, if you can hear me. As we await Dr. Olang, we can proceed to the infectious disease team, starting with Dr. Nyukuri.
Thank you, Dr. Kosgei. I'll address two issues. Number one, use of antibiotics in COVID-19, and number two, some of the investigations that you can do to guide you in your management. So when can you use antibiotics in COVID-19? We know it's pretty difficult sometimes to differentiate COVID-19 from a bacterial infection, especially before the results are out. So it is reasonable to use empiric antibiotics for community-acquired pneumonia as you await the results. But after you get the results, then and these are confirmed, it's confirmed to be COVID-19. We know co-infection, bacterial co-infection in COVID-19 is very low as 10%, sometimes lower. So if the patient starts to deteriorate, probably there's a new fever, worsening of the clinical status, increased oxygen demands. And then when you do your labs on your CBC, you get elevated WBCs. If you have access to procalcitonin, you get elevated procalcitonin. If you have access to culture and you're able to grow organisms that are associated with pneumonia, then probably there you can also consider antibiotics. But blanket use of antibiotics for patients with COVID is discouraged. Number two, which investigations can you use apart from the ones I've mentioned? So number one, CRP is a good investigation, especially if you have access to the immunomodulatory drugs like tocilizumab and baricitinib. So if you're able to do CRP and you find the CRP is elevated at about above 75, then these are, and the patient is having increasing need for oxygen, then there's a patient who you can initiate on the immunomodulatory drugs. Also, if you the dimers, and especially now in pregnancy, we were just discussing on how to diagnose PE in pregnancy, and I think you can do HRCT, especially in the patients who are worsening, and the dimer levels are elevated, and you think the probability of pulmonary embolism is high. I think I'll stop there. The other questions you're going to address in the chat. Thank you.
Thank you very much. And I see Dr. Lang has managed to rejoin us. So Dr. Lang, I don't know if you have any comments.
Yeah, I'll make a few comments. Yes, I would make a few comments. Thank you very much for giving me this opportunity to participate in this webinar. I would like to stress a few points here. I think in every institution, when you have such critical patients as a pregnant woman with COVID-19 that is already struggling to maintain her oxygen levels, and there's a possibility that you may want to have an early delivery, I think it's good to have the team already sensitized and people aware that such and such a patient is available and certain things may be needed. Now, one of the things that I personally believe in, because I've done a number of these cases, is that it is really, really difficult to intubate these patients if you have to do a general anesthesia, to give a general anesthetic to these patients. And I think in the best of centers, where one already says, I've decided on a mode of delivery and say the patient is going to deliver vaginally, I would actually encourage early placement of an epidural to help with the labor and delivery. And in the event that that labor and delivery requires that the patient goes in for a C-section, then the epidural already exists, because there are certain situations where there is fetal bradycardia, or there is APH and or intrapartum hemorrhage, and you really want to rush to theater and anesthetize the patient. And in such situations, one is tempted to do a general anesthetic. And most of the times, the general anesthetic is very difficult because it has been noted that most of these patients with COVID-19 in pregnancy tend to have laryngeal edema, and the anatomy of the oropharyngeal airway, which normally in a pregnant woman is a bit distorted, gets even more distorted. So there is a big problem in a situation like that, and one would not really like to go and begin struggling with an intubation. If an intubation has to be done, it has really to be done by the most experienced person in the team, and it has to be done in a safe environment, minimal people in the operating room at the time, especially if you don't have negative pressure theaters, and therefore the people must protect themselves from the patient. And we have in some institution an intubation box, which was tried, and some people found it difficult to use it. I personally use an intubation box, and it has never delayed my intubation, and I do a single shot at that intubation. And we make sure the patient doesn't cough, and we make sure there is no spillage or aerosolization. So that is one of the things that one must consider. So regional anesthesia is the safest for that patient, even hemodynamically, and even for the baby who is already compromised. If one can do that and minimize any delays, because already the patient is compromised, and any degree of further hypoxemia will not just affect the mother, it will affect the baby as well. Now, these patients tend to come when they already have type 1 respiratory failure. Like even the patient who was presented, that patient came with very low saturations, low PO2s, and that was already a big disadvantage for this patient. When the patient further deteriorated and required C-section, luckily they were in a place, which is KNH in this case, they were in a place where they were able to expedite delivery. Now, what I have found in the short experience we have had with these cases is that most of these patients, when they reach a point where you have to intubate them, and you find that the lung damage from the pneumonia is more than 70% affected, the chances are that this patient's lung problem is going to even continue to progress despite the fact that you have done an early delivery and therefore relieved the stenting of the diaphragm. But that does not mean that we give up on them. It means that we keep trying. And that is why when you have already done the delivery, they tend to have a period of 2, sometimes even 3 days when they are actually on the mend. They tend to be improving. And if they do not remain in that state of improvement, and then they suddenly start requiring more oxygen and more support, then from the experience we have had, the chances are you are unlikely to get that patient out of that situation. And most times they will either progress to chronic lung disease and therefore will even probably be discharged. If they survive, they'll be discharged on oxygen to be on oxygen at home and to continue management by the pulmonologists. We don't have enough experience to know how long they take on using home oxygen before they are actually weaned off that. That one we don't know. We also know that in the best of centers, there is the option that when the lungs fail completely, when you can't oxygenate adequately and you can't wash out carbon dioxide adequately, when you have both type 1 and type 2 respiratory failure, then there is the option of resting that lung, doing a bypass for the lung, and that's where Ecmo comes in. Ecmo is not much available in this country, and actually we don't have much experience with it. We are just beginning to start using Ecmo, and it is not something that gives you like a magic bullet in the management of these patients. But I think that by the time a patient requires Ecmo, the patient is likely later to require a lung transplant. And they will continue. They don't seem to respond as well as the other patients in terms of resting the lung and making the lung recover. And they may eventually just require lung transplant, which we all know is not available in this country at the moment. And I think the most important thing is the preparedness, the teamwork, and being more careful and logical about it. Remember that spinal or epidural anesthesia can lead to intraspinal hemorrhage, especially if your patient has been on anticoagulants and you did not give enough time for the anticoagulant to wear off. Clexane wears off within 6 to 12 hours. So if the last dose of Clexane was, say, 12 hours ago, like in the case which was presented to us, then you can easily poke a needle there and do your spinal or epidural. The other thing that we have also noticed is that the COVID-19 itself results in thrombocytopenia. And there are some patients who will come with even a platelet count of 20. Such a patient, you can't stick a needle in the neck, in the back. So again, one must have all those facilities available to give you the parameters that you need to be able to say this patient can safely be done, because you are not going to want to have a patient dying because of a complication of the anesthesia rather than a complication of the disease, because then that becomes another issue which becomes very difficult for you to handle. And we have had to transfuse platelets in a number of patients, and some of the private hospitals already have apheretic platelets, which we give the patients. You can give 1 unit pre-op and another unit intra-op, and there will be minimal blood loss. So those are some of the things that I think I could put up, and then I leave it for question time in case somebody has need for further clarification. Thank you very much.
Thank you very much, Dr. Olan. Now we'll go back to the infectious disease team. Dr. Louise.
Thank you very much, Dr. Rose. And thank you, Dr. Lang. I think you've also answered a lot of the questions that had come up around what is the best mode of anesthesia. So thank you very much for those pointers that you've given us. I think at the end of the day, with all the presentations we've had, it's clear that where a patient is not doing well, let's err on the side of early delivery so that we have a chance to save the mother and to save the baby. A few other questions that were asked. Someone asked about when do you decide on mechanical ventilation in the critically ill? So remember, as a patient comes in and you start them on oxygen, these are patients who you're monitoring very closely. If you're not able to achieve adequate saturations in pregnancy, it needs to be at least 92% on oxygen. If you're not able to achieve that, with a nasal cannula, you'd move on to the next thing. And if you're not able to do it with a non-rebreather mask, for example, then you're thinking either NIV or high flow nasal cannula. And if that is not helping or your patient is getting tired, then you may need to move on to providing more support. I'll direct you to, we had a 5-week series on oxygen therapy on issues around ventilation of patients, and those are on the KNH website. So please go through those again, just to review how to manage critically ill patients. The other question that was asked was around why this patient was not put on remdesivir or tocilizumab. So maybe we'll just review very quickly some of the indications. So as we know, remdesivir is an antiviral. It probably would be most useful if given early in the course of illness, because very early is when you have the viremic phase. By the time patients are coming in respiratory distress, often those patients are more of an inflammatory rather than a viremic phase. So there have been conflicting studies. Some have shown that there may be some decrease in terms of time of hospitalization. There's no study that has shown a decline in mortality, and some studies have not really shown any difference in outcomes. So it's always important to discuss these findings with your patients or with the next of kin so that they're making informed decisions. With tocilizumab, Yes, there's been data to suggest that there may be better outcomes in patients who have an inflammatory or are in a hyperinflammatory phase, so to speak. So if a patient has a high CRP, the CRP quoted in most places will be a CRP greater than 75, and they are deteriorating, then that is something that you may consider. So it's not for every single patient out there. We know the patient who may likely respond to it well. There's been a lot of use of tocilizumab in the country. Again, for those who do critical care, I may tell you that some of the experience is not always the best, and maybe it's because we give them to patients who are really sick with a lot of fibrosed lung, who do not have significant inflammation at the time it is given. So the choice of patient is important in that context. There was a question about steroid dosing. I think this patient we noted was on 6 milligrams IV OD initially, then was pushed to 8 milligrams IV TID. So I was looking at Rosie and asking her, why did you do that? Why did this patient get the higher dose of steroids? And probably part of it was because we're trying to mature the lung, though they'd probably use less frequent dosing. There is some data, and there's been a lot of controversy on whether we need to give patients higher dose steroids. So again, we don't have very good prospective studies on higher dose steroids. The best studies we have, for example, the recovery trial looked at steroids at 6 milligrams IV OD. There have been studies that have shown that in some patients, especially older patients, outcome may actually be worse with higher dose steroids. And on the other flip side, more recently, there's some emergence of data on use of maybe slightly higher doses or slightly longer, especially in patients with significant lung fibrosis. So this is an area that you're going to keep watching closely to see, whether better data comes out. As for now, the standard dose for steroids in patients with severe COVID is 6 milligrams OD of dexamethasone, or you can use an equivalent steroid where someone is not able to use dexamethasone or where it's not available. I think I will. Okay, sorry. So I think I will stop there for now. Continue with the questions. There's just one where someone has asked about the issue of antibiotics, and Dr. Nyukuri had very ably answered this. Most of your patients coming early.
Dr. Rice, before you move on the issue of steroids.
Yes.
For us, even for lung maturity, we don't give TDS. We normally give it as a BD. It's we normally give 6 milligrams twice a day, and it's only for 48 hours. So I think we clarify what we have been doing is we give the dose for lung maturity because there is a probability of early delivery just for 48 hours. Then we step down to the IV OD dosing.
Excellent. Thank you, Dr. Witi. So I think that clarifies that question. I think Dr. Rosie had something to add before we move on to Dr. Martin's presentation.
Yes, thank you very much, Dr. Lois. We just have one more comment from Dr. Walong. He's in the house. And just also to mention that our colleagues from Uganda, we recognize you and we'll give you a chance to speak after Dr. Marybeth. Dr. Walong, for 1.5 minutes, just make a comment on whether we should have done a postmortem, what it would help in retrospect. Dr. Walong.
Thank you very much for the question. Indeed, we are actively performing postmortems. We started out by performing minimally invasive tissue sampling, where we do not fully open, but we test various tissues, for particularly target tissues being lung, brain, and liver. And with that, we could establish the cause of death in more than 60% of cases. And when we combine microbiology, we have started seeing certain patterns of infections, particularly in some circumstances, nosocomial infections or other co-infections in COVID. So it's an area of interest that we are developing so far. In terms of full autopsy, we also perform full autopsy. We are now confident enough to do it. We have our autopsy team fully vaccinated, and biosafety is adhered to as expected. And from that, we've already started seeing additional patterns of COVID-related pathology, especially in this population where we do see occasional postpartum mortality of someone who was managed, went home, and came back again with similar disease. And with that, we already have an idea of what is happening in terms of long COVID and, of course, acute COVID-related mortality. So I would encourage you to request for these autopsies as much as possible. We will do them, and we will provide this information for your respective mortality meetings. We already have experience with maternal mortality, but now we want to strengthen infectious disease mortality surveillance as well. Thank you very much.
Thank you, Dr. Wallon, for keeping that 1.5 minutes time limit. And colleagues, we all now agree that if we can prevent this, if we can avoid to let our women, our mothers, get into this critical condition with COVID-19, we really must preach and we really must talk about vaccination, and we must have every pregnant mother get vaccinated. And just to take us through this, we will now invite Dr. Mary Beth Maritim to just take us through a short presentation on COVID-19 vaccination in pregnancy. Dr. Maritim.
Good morning, everybody. I hope you can hear me. Good morning, everybody. Can you hear me?
Yes.
Okay. Yeah, just allow me to share my screen. 1 minute. Yeah, so I'll take us through this short presentation on COVID-19 vaccination in pregnancy. And this is a recurrent discussion on every webinar that we're having in this series of COVID-19 and pregnancy. And therefore, I just have a few slides I want to share and to hopefully cover some of the discussion points. So this is the outline of my presentation, looking at decision-making for COVID-19 vaccination in pregnancy, then recapping on COVID-19 and pregnancy and the risks for severe illness, and then going through COVID-19 vaccine in pregnancy. What do we currently know in terms of safety, efficacy, and effectiveness? And then to conclude really with the Kenyan context in terms of where are we. So in terms of decision-making process for COVID-19 vaccination in pregnancy, these are some of the considerations. So individualized informed decision about COVID-19 vaccination in pregnancy. These are some of the things you would consider when you're having this risk assessment. So the risk for infection in the person you're really looking after, the risk for severe disease and negative outcomes from COVID-19 infection. And last week and this week, we've really echoed this, and this will be a common theme as we go along. Definitely from the cases that have been presented so far, we know that pregnant women who have been discussed on this forum have had severe disease and have required admission. The only challenge is that I think at the national level, we don't really have data in terms of what proportion of the pregnant women progress on to severe disease. It's currently estimated to be around maybe 2%. And then the last thing is around risks and benefits of vaccination for pregnant people at this time, given the current state of the evidence, and the evidence is still building along this point. This was discussed at length last week by Dr. Kihara, and again, we've seen some of these risk factors in the case that has been highlighted today, and some of these were even in the case last week. So risk factor for severe morbidity from COVID-19 pregnant individuals has been shown to demonstrate some of these risks. So age older than 35 years, asthma, obesity, pre-existing diabetes and hypertension, and heart disease. So we see some overlap with some of the chronic medical conditions that would even confer the risk in non-pregnant individuals. We've also seen from global data, and has been discussed by the panelists, that there's an increased risk of preterm birth, which has been said to be iatrogenic. And this is associated with COVID-19 infection in pregnancy. And therefore, in terms of weighing to save the mother and the baby, those are some of the things that contribute to the risk of preterm birth that we are actually seeing. And I think the saddening bit is where you have an infant surviving, but the mother is not there. And that presents a challenge for the family. Somebody has to mute. There's a panelist whose microphone is on. So when you're doing a risk assessment, when you're performing a risk assessment for acquisition of COVID-19 in a pregnant woman, these are some of the questions you need to ask. But you have to remember, particularly in our setting, in our local epidemiology, we have widespread community transmission. And therefore, some of these questions may apply when you have maybe clustering of cases in certain regions, but therefore some of the questions may not necessarily apply. But these are some of the things you'd need to ask to be able to tell your patient maybe they're at higher risk and where you're doing a risk-benefit assessment. So the first question is, does your patient work in a high-risk environment? For example, if they're frontline workers and more so healthcare workers. So this term of frontline healthcare workers earlier in the epidemic was a bit clear because there was a national restricted movement. People were allowed to work from home. But we know that increasingly people are venturing out to seek their daily bread. And therefore, we can almost say that everyone really is now more or less a frontline worker. The second question is your patient in contact with people who cannot follow safety precautions, for example, masking and physical distancing? And this is really important in a household where you have children that go to school that wear a mask, and you can't guarantee that they adhere to the masking all the day, where you have children maybe under 5 or under 10 who are coming into the home environment. And therefore, even within household, you might say that this then would be a yes for most of the people, where you have children who have to go to school and come back home, and you can't guarantee in terms of adherence to the public health measures that would put the mothers in the household at risk. And then the third question would be, does your patient have an increased risk of exposure due to social factors? For example, if they have low socioeconomic status and therefore they live in very clustered settings. Maybe we know currently our situation with the transport system where you don't really have social distancing measures within our public transport system. And therefore, this would put your pregnant mother at risk, not necessarily because of low socioeconomic status, but more so because of certain non-adherence really to public health measures. In other settings, for example, if you were looking at the US, this may have a different meaning whereby people of low socioeconomic status may have poor access to healthcare, and therefore, even when they get COVID, then they would have poor access to care. But in our setting, you have to contextualize and see what are the circumstances that put people at increased risk due to exposure as a result of other social factors. The fourth question would be, does your patient live in a group setting where COVID-19 virus may transmit more easily, such as correctional facilities, shelters, or group residences? And this may be also in the informal settings where they may be closed housing, small houses where many people live within that one space. So social distancing cannot really be undertaken. So these are some of the questions. And looking really in our setting, it means that a lot of our patients, if we were to perform this risk assessment, a lot of our patients would score yes in many of these questions. And therefore, even if we were to perform the risk assessment, it means a lot of our pregnant mothers, the risk for getting COVID would be magnified. And therefore, even if you're trying to do a risk assessment, because in the WHO guidelines, it recommends where you use a tiered level. And if someone has a high risk of COVID, then you may consider vaccinating them. And therefore, it means a lot of our pregnant women would therefore qualify for vaccination. This, again, I cannot really overemphasizing it, but this is where you want to assess for development of severe COVID in pregnancy. And we've already highlighted the risk factors, and they have been demonstrated in the case studies that we have had so far. So I don't want to overemphasize. It was linked to my previous slide, but now putting it in question form. And therefore, when you're looking after patients who are older than 35 years, have a high BMI, have pre-existing medical conditions, have other complications of pregnancy, such as gestational diabetes and hypertension, and increased risk of severe infection, and they're not yet vaccinated, these are people who you really need to prioritize to receive their vaccination, because should they get COVID-19, because of the factors that were in my previous slide, they're likely to progress and develop severe illness. This slide is busy. but it's deliberate because we've discussed mechanisms of actions of other vaccines prior to this. In this today's session, we're just looking at the vaccines and pregnancy. But to remember, Oxford AstraZeneca vaccine and Janssen vaccines, they're viral vectored vaccines, but the virus is inactivated. It's modified adenovirus vector that does not replicate in the body, but it transports the spike protein that now serves to deliver the spike protein DNA into the host cell. And therefore the host cell produces the spike, the antibodies in response to the spike protein. So it's the same mechanism of action we've discussed previously. For your mRNA vaccines, of which now we have 2 in country, the Pfizer vaccine and Moderna vaccines, they're both messenger RNA vaccines that have the mRNA encoding the SARS-CoV-2 spike protein, which is introduced into the person through a lipid nanoparticle coat. The mRNA does not go into the nucleus, and therefore it does not integrate into the host DNA. So these are the vaccines that we have robust data around their use in pregnancy. And therefore, when you're looking at the efficacy of these vaccines, the data that we have is really from the non-pregnant population rather than from clinical trials, because clinical trial did not recruit the pregnant women. So the efficacy remains what we've discussed previously. For the Pfizer vaccine, 95% efficacy at clinical trial. It's given as a 2-dose vaccine. The Oxford AstraZeneca vaccine, again, 66.7% efficacy against symptomatic COVID-19, given as a 2-dose vaccine. Moderna vaccine has a 94.1% efficacy, given as a 2-dose vaccine. And the Janssen vaccine is given as a 1-dose vaccine, has a 66% efficacy. And therefore, this is data from non-pregnant population. And real-world monitoring has confirmed that even a single dose of Pfizer vaccine or Oxford AstraZeneca vaccine would confer about 60% protection against symptomatic COVID-19 vaccine. When you give the 2 doses of Pfizer or AstraZeneca, they've been shown to be effective against symptomatic disease that's caused by the Delta variant. So again, protective against the most dominant variant for particularly the 4th wave that we've witnessed recently. So looking at COVID vaccines, specifically in pregnancy, I've already talked about the first bullet. These pregnant women were not included in the large randomized control trials. However, several individuals who participated in the clinical trials did become pregnant over the course of the trial and have been followed with no reports of adverse events to date. We have a big registry in the US. It's called the VSAFE CDC registry, which recruits and monitors patients following immunization for adverse event. And within that registry, they actually followed up pregnant women. And this is where a lot of the data, safety data, has come from, where they've reported no difference in rates of adverse events or pregnancy complications for those women who are pregnant and received either the Pfizer vaccine and Moderna vaccine. And many of you know that AstraZeneca vaccine is not being administered in the US. So that registry may not provide us data for the AstraZeneca vaccine, but J&J vaccine is being given, although with their guidelines, the mRNA vaccines are preferred or recommended for the pregnant women. So coming back to what we know about the vaccine, Prof. Nzala alluded to this study, and this was a rapid review undertaken by the COVAX maternal immunization study group, working group, to look at what can they gain from data on existing platforms. So when you're talking about a platform, you're talking about the delivery system. So some examples of platforms you're talking about are the mRNA, for which now you're using a novel RNA technology. You're talking about the adenovirus vector, that's the platform. So when you're talking about the platform, is the delivery system through which the vaccine is introduced into the body. And in this study, they really wanted to see, for the existing vaccines under the COVAX initiative, are the platforms safe, and where can they get the data regarding the safety? Because some of these platforms have been used for other vaccines in the past. So in this rapid review, they really wanted to look at the vaccine safety during pregnancy, and they conducted a systematic review looking at the safety of the COVAX vaccine. This was undertaken by the Maternal Immunization working group, because it would be a concern if you're using vaccines that may not be safe in pregnancy. And that's really the reason why this study was done. And they included components and technological platforms that had been used for other vaccines in pregnancy. And some of the vaccines then they looked at were influenza vaccines that were already being deployed, among other vaccines, including even Ebola vaccines that have been deployed during pregnancy. So they looked at different literature bases, pregnancy registries, reference lists for a certain period of time, and they didn't restrict the language of the search. So they retrieved a lot of records, close to 7,000 records, including data from 12 COVID-19 vaccine pregnancy registries. And the number of people who are involved, or the data that were analyzed, included almost 2.4 million pregnant persons. And this also included animal studies. So about 56 pregnant animals were included. So what is to note is that most of this data was derived from studies that have been conducted in high-income countries. And this is because they have very good registries that follow up people on a long-term basis. And then a large proportion of the studies, again, compared vaccine exposure vis-a-vis no exposure. So there was no control, there was no active placebo. And this was during the 3 trimesters of the pregnancy. So most commonly used exposure in these studies, because the biggest vaccine that was used, or the vaccine that was given to most of the pregnant women, were the influenza vaccine, a vaccine called Pandemrix, that used an adjuvant, the AS03 adjuvant, in the context of the H1N1 influenza vaccine. And this was a common adjuvant. But the current vaccines we are deploying in Kenya, none of them has this adjuvant. So I don't want to highlight too much about it. But one study reported exposure to mRNA lipid nanoparticles, the COVID-19 vaccine. And in the conclusion, they found no evidence of pregnancy-associated safety concern and their components or platforms when used in other vaccines. And however, the caveat is that there is need to collect further data, because when you're looking at safety, you look at long-term safety. So you have to follow up participants over a long period of time. And therefore, these findings from this rapid review support the current WHO guidelines that recommend that pregnant person may be considered to receive COVID vaccines, particularly if they're at high risk of exposure or have comorbidities that I've already alluded to earlier in the presentation. So coming back to the real world data, I'm almost finishing. What we currently have is more than 200,000 women in the UK and US have had COVID-19 vaccine in pregnancy. And so far, there's been no concerning safety signals from the registries. As of June 2021, this is a bit dated data, over 120,000 pregnant women from diverse ethnic backgrounds in the US had received the mRNA vaccines, and this I've already discussed. This is their preferred vaccine in that particular setting, but there's no evidence of harm that has been identified. So in general, there are known risks from giving inactivated or recombinant vaccines in pregnancy or while breastfeeding, and there is therefore no reason to suppose that these adverse effects from these COVID-19 vaccines should be different for pregnant women compared to the non-pregnant women. So as a general guideline, it therefore means even when you're weighing the risk and benefits, we've seen from the presentations that the benefits definitely outweigh the risks. For people who are contemplating a pregnancy, and this was discussed again at length last week, for an individual planning a pregnancy, it's best to complete the COVID vaccine series to achieve the maximum vaccine efficacy ahead of the pregnancy. So I put this slide from the Johns Hopkins tracker that's looking at countries that have a vaccine policy. And we can see there, I can zone down on Kenya. Kenya actually does not recommend COVID vaccine in pregnancy. It's like some of the other red countries that do not recommend COVID-19 in pregnancy. So having said that, there's this statement from COGS, which has really taken the lead and provided guidance. And what basically COGS recommends is that it strongly recommends that pregnant and breastfeeding women should have access to COVID vaccines. They've actually I just took a screenshot, and they provided a synopsis and synthesis in terms of providing the justification. And this is just the summary or the concluding paragraph, where they strongly recommend that pregnant and breastfeeding women should have access to COVID-19 vaccines and should engage in a discussion about potential benefits and unknown risks with their healthcare provider. And we've already seen about balancing risks and benefits, and clearly the benefits outweigh the risk. Counseling should balance the lack of data on vaccine safety for the fetus and risk to pregnant women from COVID-19 infection and individual risk for infection and severe disease, like I've alluded to. And it provides additional guidance in terms of what needs to be done in terms of collecting this additional data to support the evidence locally, to generate more evidence locally. But clearly they demonstrate that, that pregnancy poses increased susceptibility to or a severity of disease, and the best approach to protect the infant is through passive placental antibody transfer, which is the most efficient and direct protection to the newborn before an infant is vaccinated. And therefore, in general, it's recommending vaccination of the pregnant women. So we still await a guideline from the ministry in terms of how to go forward. I know last week in the questions, in the Q&A, this came up frequently. So we'll share this COGS guidance through the chat so that people can have access to it, because that's the best we can have at this point as we await the ministry. So in conclusion, this is my last slide. The current data really shows that COVID vaccines are fairly safe in pregnancy, and definitely the benefits outweigh the risk. So we should be vaccinating more pregnant women. So thank you so much. And we'll take any questions that may arise.
Thank you, Dr. Mudemba, for that wonderful, wonderful presentation. And the message is clear that we should recommend vaccination for our mothers during the preconception period and even in pregnancy. And so even before we go to the question answer, if you have any questions, you can start putting them on the chat. We want to now invite our colleague listening all the way from Uganda, Dr. Mukuzi Muhereza. Is the Secretary General of Uganda Medical Association. Dr. Mukuzi, we will give you 2 minutes, and as part of your comment, really, we also would like to hear, in the spirit of knowledge sharing, which is what we are doing in this particular series of webinars, what's your experience briefly? Over to you, Dr. Mukuzi.
Thank you very much, Rose. I will not go into protocol, but I'm very, very elated and happy that this session is going on. Once again, warm greetings from Uganda. I can see some few participants from this side. And in the spirit of knowledge sharing, I want to really say that the same challenges, same problems, same approach almost. And what I can say is these similarities, especially the troubles somebody goes through. Rose and everybody over there, I'm a clinician. I work almost daily with patients in a relatively small hospital, not small, 100 bed, but not in the city. And they're thinking that Kenya stops in Nairobi or Uganda stops in Kampala. Definitely there will be people out there with not the same resources that you have, not up to date with everything that you guys have, or people could be in Kampala be having. So such sessions are very important. Such sessions are definitely important, such that we learn and we share with each other. I have put the face, maybe such that people can have the gist of the person speaking. So these decisions that when we are to make a decision on which sort of anesthesia, because this is something that trickled me out because I've dealt with somebody like that. You cannot prop somebody to get a very good spinal, but at the same time, somebody is needing to be worked on. You may not have all the things that you would need. So such things that we face on a day-to-day practice. And when we get such knowledge, we really appreciate. The next thing that happened is that a death of a mother, especially here in Uganda, it becomes almost like a criminal case. There must be a maternity audit. And 80% probably you find that the causes or the problems lead to the system, not the knowledge, not what a physician would have done or a surgeon would have done, but what was missing in the system. I'm not reporting myself, I'm not reporting the country, but I'm saying that this could be the same thing that you guys face. So how, as associations, as groups of practice, how can we confront these and make ourselves safer to work in this process? But at the same time, how can we, as patients, because we're also probable patients, how can we be better managed the next time when we need this? I want to use these few minutes to really congratulate you for this knowledge sharing. It's not every association, it's not everybody that attracts almost 1,000 participants. So keep it up, hook us in. We have one of our very active branches in Ukuru, and we are going to have one tomorrow. I think it will be about, of course, not yours, but it will be about, let me remember. Yes, female, I don't want to call it them election dysfunction, but it is female dysfunction, especially in sex area. So I will share with Rose the link. Whoever would attend, it would be a pleasure. I want to thank you once again and say Asanteni and let the collaboration continue. Over to you, Rose.
Thank you very much, Dr. Mukuzi, all the way from Uganda. And now we'll quickly shift to the question answer. I'll try to skim through what I feel that has been answered. In the interest of time, we'll not talk about that. But just to start us off, that one of our frontline worker, Mildred, who lost the battle to COVID-19 in pregnancy, funeral service is ongoing right now, and I would like to request us to just observe a moment of silence for her. Thank you very much, and may the good God rest our soul in eternal peace. So we'll start off with most of the questions remaining unanswered related to the vaccination in pregnancy, and we'll direct them to Dr. Mary Beth. And one of the questions here is, one, is it advisable to get Moderna vaccine after getting a shot of AstraZeneca early in pregnancy? So the issue of mix and match. And the other question again is, what if a mother, that one had already been answered. I think the main question is that one of mix and match of vaccines. So over to you, Dr. Mary.
So like I said, we don't have clinical trial data for some of these studies, particularly the mix and match studies have been done more recently, particularly in Europe, in the UK and in Spain as well. And some of the countries went ahead and implemented mix and match without necessarily clinical trial evidence. So the question at hand is, someone received a first dose of AstraZeneca. When they went back to the facility, they have been told that AstraZeneca is out of stock. And therefore, the question is, can they receive Moderna vaccine as a second dose? So from science, it's possible that you can actually mix and match different vaccine antigens because you're able to elicit an immune response. But like we said, even last week, this was, I think last week's question was outside of pregnancy. And the answer I gave is that the national policy or deployment vaccine policy currently is that if you received a first dose of one vaccine, your second dose should be of the second vaccine. So my answer would be, at the moment, I think maybe the facility may provide more guidance around that, because maybe there are some doses of AstraZeneca that are anticipated for those people who are due for their second dose. So at this point, even if you went to any facility, they won't give you a Moderna for your second dose because that's the current deployment policy. But scientifically, there should be really no problem with mixing and matching. But as per the guidelines from the Ministry and the Vaccine Deployment Task Force, we are not, as a national policy, mixing and matching. So that's the answer I'd say.
Thank you very much, Dr. Martin. The last question for today from the question and answer will be answered by Dr. Lois. And the question is, kindly remind me the role of zinc in COVID treatment. the key sign in chest X-ray for COVID patients, and lastly, the workable support treatment and antibiotics that are locally available. The issue of antibiotics has been handled very well already. So I think the main thing here is just a comment on zinc in COVID treatment. Over to you, Lois.
Thank you very much, and thanks for this question. This is something we've talked about severally in our previous webinars. So there's been a lot of use of supplements, so zinc, vitamin C, vitamin D, and many other supplements. Some of these have actually gone through clinical trials, randomized clinical trials, looking at whether they made any impact on disease progression. And so far, we do not have any data to suggest that zinc or vitamin C or vitamin D make a difference in outcomes. So spare your patients the cost of having to buy all these supplements. They are not going to change the outcome of disease as far as we know at this point. Encourage your patients to continue having a balanced diet and to exercise, to keep active, and to present to hospital should there be any worsening of symptoms. In terms of key sign in chest X-ray. So maybe one of the things to say is that in patients who have mild to moderate disease, there's really no role for imaging. It will not change what you do. If you have a patient with severe disease who's deteriorating despite the management that you've given, then in those patients, you could consider doing imaging. And really what you want to see, one, extent of disease, because it may help you with planning in terms of requirement for critical care, but also to see if there may be something else that explains the severity or the non-improvement on care. So remember, not every patient needs a CT scan of the chest. Not every patient needs an X-ray. Only do this in patients with severe illness who are deteriorating on care or patients with critical illness. I think that was the main thing. I'm not sure what workable support treatment is, but we've talked about treatment severally, and we'll soon be launching the treatment guidelines so that you can have this to refer to frequently. So thank you very much, everybody, for... Sorry, Rosie.
That's okay, Lois. I just needed to, since this is a really important topic, I needed to give each of the panelists 30 seconds, starting with our very young panelists, just to make any comments.
Kosgei, this is Anzala. I just want to hear, I have one comment, and I want to hear this from the obstetricians. I think we have been told before from those who have come before us that there are always three sides to the coin. As we engage critically in those who are SARS-CoV infected and COVID, I'd like to know from the pediatricians, beginning with Professor Gutu, what percentage of our women who are coming in with pregnancy with SARS-CoV-2 are completely COVID-free? Age notwithstanding, what else are we learning from them? Because science tells us that we have to learn from all the sides of the coin. So could I hear what we have learned from that group as far as the registry is concerned and as far as your management is concerned? Those who are remaining disease-free, who are they and how do they look like?
Thank you, Professor Nzara, for that question. I think one of the biggest problems we have within our country is that there was a bit of a problem of recording the number of patients who are tested positive for COVID and the aspect of pregnancy is recorded. From the last I checked, which was 2 weeks ago, the ministry data reports that they have less than 5%. In actual fact, the actual figure was about 2.9% of patients who have been tested and are COVID positive who are pregnant. But the data coming from some of the private hospitals where they're doing this, the tests are almost coming up to 10%. But the good side of the coin is that most of the patients who are tested and are found to be COVID positive actually are asymptomatic. It's only a few, less than, if I can talk of what they have, I think in Nairobi Hospital, is less than 2% who have been shown to be having those symptoms, which would require somebody to be able to either start thinking of intervention or just being able to manage them so that at least the symptomatology go down. So that is the case. But of those patients who are COVID positive and are asymptomatic, they go through their pregnancy just like any other person, any other pregnant woman. You just need to manage them, let them know that they are COVID positive so that they at least take all the other precautions as required. And then you can be able to deliver them at the normal time any other pregnant woman will be able to be delivered at term. But in the event that they are showing severe symptomatology, then at that time, individualization of the patient has to be taken into consideration. And then you deliver when it is appropriate and so that you get a good outcome in this patient. Unfortunately, there might be some who may come when they're already too sick, like the case we presented here. So each and every case has to be looked at individually. But luckily, most of our patients, as seen in the general population, those who are COVID positive, majority actually are asymptomatic. Thank you.
So then, Prof, what can we learn from there? Because you see, we must learn from both sides. Is there a way we can organize ourselves to begin to learn from that side as well as we learn from those who get sick? Because this is what will make us now predict, have markers of prediction. Get to know age is just one thing. What else? Is there something that, because pregnancy is a special group, is there something you obstetricians can put together so that we begin to map these guys and learn more? COVID is going to become endemic.
Agreed.
Yes. So what is it that you guys can put together? And for me, really, it is always looking for more information to inform ourselves, rather than keep talking of Europe, US, Australia, Asia. So I'm challenging you, Prof. What else?
Agreed. I think the bottom line is that we should be more proactive and be able to test our patients so that we know who are the ones who are positive. And then once they are positive, a question of trying to look at what is it that the COVID can be able to do to our pregnancy. Now that you asked this question, Professor Nzala, as obstetrician, our biggest worry currently is that by the time the patients come and they find a mother who is sickly, showing all those signs of flared up COVID disease, it's almost a lost game. What we are seeing now is that even some of those patients who may be having just what we consider to be a mild disease, there's a component, as Dr. Walong will tell you, of the placental events, which therefore explains why we're having a slightly increase in early pregnancy, preterm births, and also IUFDs because of those changes. So the question the lesson we need to learn here is we follow our mothers, do our testing. Those whom you think are positive, we should be able to follow them up and be able to ensure that we get a better outcome in this patient. And probably this might be at a different levels. We look at some of those patients we have and we look at what is it in them which we can be able to develop as a predictor to some of the adverse outcomes. And those are the lessons we can be able to learn once we have a cohort of patients whom we already know that these patients are positive. Let's start them from earlier on. And from the lessons we learn from them, we can be able to start having predictors of what can lead to a severe disease or lead to a poor outcome. And therefore we see what are the things you can put in place to be able to ensure that you get a better outcome of the fetus. If it is something the placenta, is it that they're having increased events of having thrombotic events in the placenta? Do we put these patients on anticoagulants earlier on as a prophylactic? I'm just thinking aloud, like we do in women who have got recurrent losses. And this can be some of the lessons we learn, but is a food for thought for us to start thinking aloud and develop areas in which we can be able to improve knowledge and we can be able to have a better outcome for our women.
Thank you very much, Professor Ogutu, and thank you, Professor Nzala, for getting us to think about lessons learned and how to improve outcomes going forward. And I think it reminds me of a comment that I think one of the residents had made earlier about any suggested areas for study. I think there's still so much unknown, even just describing our patient profile, looking at predictors of outcome would be very important areas for study. So any of the residents who are here, I think those are things you can begin to look at so that you're able to, bring together and collect our data and actually learn something that improves outcomes of our patients. So we just want to thank you all for your participation today. There was one question that someone I think has asked quite a few times. Proven role of aspirin? No. Do we still give warfarin in PE, in COVID, or Clexane only? So if you have PE, we'll usually start with the unfractionated heparin, then transition these patients to warfarin for longer term care or other oral therapy where possible. So for example, the directly acting anticoagulants, that may be a possibility. And where patients are not able to take this, you may have challenges with monitoring INR, then you could also continue with Clexane. So maybe what we could consider doing in one of our future webinars is specifically look at issues around clotting and other issues around coagulation disorders. Should we continue Clexane with thrombocytopenia? So one of the things when we're using heparins generally is we need to be careful that we do not, that we monitor for any issues around heparin-induced thrombocytopenia. Remember, if you have thrombocytopenia, your risk of bleeding is higher. So it's something that you have to judge very carefully. And if you have such a patient, I would strongly suggest that you get a physician on board to help you with the management. So with that, we'll come to the end. Rosie has one announcement to make. Thank you, everyone, and we wish you a very good weekend. Rosie, go ahead.
Okay, so thank you, everyone. Thank you to the panelists. And so for the last 2 weeks, we were looking at this pregnant woman with COVID-19, and today we successfully delivered the baby. And so next week, we are going to have the pediatrics team just taking us through how to take care of this baby, even as we continue taking care of our mother at the postpartum period. And to all the panelists, asante sana. Let's meet same time, same place next week. Goodbye.
Bye.
Bye.
Bye-bye.
Thank you. Bye.